what Afrophc is and how Afrophc runs or what Afrophc does. That is how you'll know. And then from there, we will move on to a presentation on, we'll move on to a presentation by Jamie Colletti. I think she'll be joining the meeting later on the call to Africa from Afrophc, which is around the policy document on building the PHC team in Africa for universal health coverage. Then from there, we will move on to a discussion that will be facilitated by the Central Africa facilitators on what are the challenges of PHC within the Central Africa region, and also how do we move Afro-PHC forward. And we will also have a discussion on the draft policy framework, which is the policy on building the PHC team in Africa. So I hope a lot of you managed to go to the site, download the document, and at least read it. Then after that, we will conclude with the formation of an interim regional task team that will help to connect the Central Africa chapter with the Afro-PHC leadership so that we can be able to see how we can better do projects which are more localized and contextualized. And with that, I will move on to ask my colleagues to introduce themselves. We have Cynthia.
Yes,
go ahead, Cynthia.
Hello, everybody. Hello, everybody. Good afternoon, good morning, good evening. I'm Cynthia Chaiva from Zimbabwe. I'm a nurse midwife, currently a senior lecturer in the Department of Nursing and Midwifery Sciences. I'm also an executive board member of Afro-PHC. Welcome, everybody. It's good to be together and discuss issues towards building up Afro-PHC. Thank you.
Thank you so much, Cynthia. Ellie?
Okay, yes, my name is Dr. Elia Bajo. I'm also an executive coordination team member of Afro-PHC. I'm leading the CPD program. I'm also the director of COSAMED in DRC. Thank you.
Welcome very much, Eli Badjo. Eli Badjo is one of the facilitators for the Central Africa chapter. Jamie?
Hi, Mercy. Hi, everyone. My name is Jamie Colletti. I am a junior medical doctor from South Africa, currently completing my community service medical year in the South African Military Health Services. I'm a member of the Afro-PHC Executive Coordinating Team, the clinical lead for our clinical teaching workshops that is developing a postgraduate diploma in family medicine curriculum. And I'm also part of the team that is doing CPDs. Thank you.
Thank you, Jamie, and thank you for joining us today. I will move on to, let me see if we have any other member of the Afro-PHC team. Umar Ibrahim. Umar, I don't know if you're speaking, but we are not able to hear you.
Yeah.
Hello, Ibrahim? We are not able to hear you. Maybe you could switch off your video so that your audio can improve in quality and we'll be able to hear you.
Okay, can you hear me now?
Yes, we can. Please go ahead. Oh, I think we've lost you again, Umar.
Can you hear me now?
Yes.
Okay, let me come over again. I am Dr. Umar Ibrahim. Head of Department of Public and Environmental Health, Duze, Nigeria. My focus are on changes across Africa. A lecturer, a researcher, invited to say Africa.
Hello? I think we keep losing you, Omar. Maybe you could just type in the chat. I'll move on to Francois. Francois, please go ahead. Hello, Francois, are you there? Hello? Hello? Okay, so I am going to move around the room and I'm going to call out people from the order in which they appear on my screen. And I'll ask you to introduce yourself, which country you're from, and if possible, please you can rename yourself so that you can have your name and the country you're from next to your name. So I'm going to start with Anna.
Hello, everybody. I'm Anna Dania, and I'm living in Finland, Europe, and I'm participating in the activities of Afro primary health care through my acquaintance with Shabir. And I'm trying to support the development of practice-based research networks in the primary care and research capacity building in Africa. Both in Africa, and I would like to help also to assist to have some funded projects with collaboration of African countries and professionals and European countries or America and so. I have a role also with VONCA, Working Party on Research. I'm leading a movement, an initiative for the development and sustainability of practice-based research networks around the globe, and especially in not well-developed countries in the primary healthcare, on the primary healthcare perspective. And we are trying to develop cross-continental collaborations on the benefit of primary healthcare and family medicine. Thank you.
Thank you so much, Anna, and thank you so much for joining us. It's a pleasure to have you here, and thank you for the support that you're giving Afrophc. Next, I will move to someone who has named himself at KGB. Okay, I'll move to Daniel.
Hi, everyone. This is Daniel. I'm a medical doctor. The first time I participate in this forum. I have been invited by one of my WhatsApp group, and then I decided to participate. And I'm working for Save the Children. I'm in Rwanda, and I'm the clinical lead for primary health care and Save the Children. Thank you.
Thank you so much, Mambo, and it's great to have you here with us today. Daniel.
Daniel.
Yes, Daniel. Mambo.
Yeah.
Go ahead, Mambo, you've raised your hand. Okay, I will move on to somebody else. We have John. John Walasa. Go ahead, John. All right, I will move on to Shirley.
Thank you. I'm Shirley Fambula. I'm a nurse. I live and work in Liberia as an IPC specialist during our Ebola and COVID crisis. Right now, I'm working with a project Bridge U at the University of Liberia, where I'm coordinating activities regarding research and policy. Thanks for having me.
Thank you so much, Shirley, for joining us today. It's great to have you here. Theory. Theory Mungumo. Okay, I will move on to Endada Zawadi. Theory, go ahead. Go ahead and unmute and introduce yourself. Remember, in case you need French interpretation, French English interpretation, just click the interpretation button and click your preferred language. We have Alexander, our interpreter, here with us, so you can use either French or English.
Okay. Are you getting me?
Yes, we are, Thierry. Go ahead.
Okay, I was muted before. I say my name is Thierry Mungumwa. I'm a medical doctor and I'm from a general practitioner. I'm from the Democratic Republic of Congo, but now based in South Sudan. And I'm also a student. I'm doing a master's in public health, health promotion and international health. Thank you.
Thank you so much, Thierry. It's a pleasure to have you with us today. I will move on to Mambo. Mambo, go ahead. Okay, now I will ask for anyone else who has not introduced themselves, in case I missed you, or you've just joined the meeting and you'd like to introduce yourself, please go ahead. Mbilizi, would you like to introduce yourself? Okay, Francois.
Me.
Yes, Francois.
Okay. Good afternoon, everyone. My name is Nwabufo Francoise from Cameroon. I'm a nurse midwife and a fellow with the West African College of Nursing. I do lecture in the university over there in Cameroon, and I am the Deputy President for Afrophc. We are indeed glad to have you here and to launch our Central Africa chapter. So expecting that you'll be with us till the end of the program. Thank you all.
Thank you so much, Francois, and it's a pleasure to have you with us today. So I'm going to move on to the introduction to Afrophc. It's going to be a short presentation just to let you know what who we are as Afrophc and what we do. And I'm going to ask, if you're not speaking, please keep your mic muted. And again, for those who need French English interpretation is available. Just click the interpretation button at the bottom of your screen and choose your preferred language. So Afrophc, or Africa Forum for Primary Healthcare, is a network of healthcare professionals from all over Africa who are trying to build up and represent the healthcare agenda, the primary healthcare agenda in Africa from an African perspective. And I'm going to start by giving a short background of Afrophc, where Afrophc started. So the idea for Afrophc started in 2019 in Kampala during the Wonka Africa Conference, with Prosper Tumusime, who has even previously been an executive board member at Afrophc, where there was a suggestion that we have a forum like the European Forum for Primary Healthcare, where they have a forum that specifically deals with the issues, challenges, anything to do with research. The European Forum for Primary Healthcare deals with that. And so there was a suggestion that Africa should also have this. So that's where the idea started. Then from there was in August 2019, during the African conference in Nairobi, an interprofessional practice and education network that is Afripen. During that time, people sat down, that is Bonge Sebanda, Champion, and Prosper Tumusime from the WHO sat down together and decided they need to draft a proposal and move the idea forward. So in September 2019, that's when the proposal was done in response to the UHC declaration during September 2019. And this was something that was embraced and supported by organizations like Wonka Africa, ANAC, APN, which are also supporting organizations for Afrophc currently. And from that point forward, Afrophc was started. And this is the vision and mission of Afrophc. Like I mentioned before, healthcare workers who are on the front line of primary care services in the health systems of Africa and supporters of the primary healthcare approach, who are committed to achieving universal health coverage in Africa. And it is, however, very easy for UHC to be seen as a financial solution without the required reform in primary care service delivery. So the centrality of primary healthcare to UHC efforts may become lip service, especially when primary care workers' voices are ignored in Africa. So the whole pitch was around how important is primary healthcare in achieving universal health coverage, especially in the health systems in Africa. So the plan was to bring together the leadership of all healthcare workers at the coalface in Africa primary healthcare and ensure that we all have a voice in policy on primary care and primary healthcare in Africa. And we hope to develop an Africa Forum for Primary Healthcare as the voice of primary care and primary healthcare team and its supporters, sharing and supporting each other in advocating for PHC. So during the formation of the Afrophc, this was the initial goal and this was the initial vision that Afrophc wanted to achieve. So Afrophc having been launched, we started in 2020 with an initial workshop where there was introduction and then a launch workshop in September 2020, where people got to know each other, everyone who had come together to start PHC. And during this workshop, they emerged with an Afrophc statement with key principles being primary healthcare as people-centered, with primary healthcare, human resources, capacity development, teamwork, and inclusive primary healthcare leadership and advocacy as being a very key issue in universal healthcare coverage in Africa. Then after that, there was an Afro-PHC for UHC workshop in December, where they reflected on the statement and workforce issues for PHC in Africa. And there was a further discussion during the Africa Primary Healthcare Network Symposium in November 2020. So the official, there was an Afro-PHC launch and AGM on 20th April 2021. And during this time is when an executive board that runs the activities in PHC, in Afro-PHC was formed. And these were the initial board members of Afro-PHC. It started off with around 164 members, then for 37 members. And those are the members that selected. 220 members are the ones that voted this board in. And later on, we co-opted Champion Nyoni, Marie Claire Wangari, and Tolu, who are still currently on the board, but I think Marie Claire stepped down. So the board is made up of 9 people from around Africa. You can see their diversity. So the executive board, of which we have some members here who've introduced themselves, are basically the leadership that runs and keeps Afro-PHC running, and also keeps the executive coordinator and the team accountable. In terms of stakeholder engagement, since the launch of Afro-PHC, we have 31 Afro-PHC supporting organizations. You can look them up on our website. We have an advisory board set up that meets every month. We have engagements with the WHO Civil Society Commission, and we also have engagements with WHO Africa to get a non-state actor status that will enable us to participate more in the global healthcare space. We also have an EOSIS partnership on a journal where we can publish primary healthcare research specifically from Africa. And we also have a youth hub to engage youth organizations. And the youth hub has actually come a long way in engaging students and student-led organizations. Another way in which Afro-PHC has been growing and making a difference is through the policy workshops. So every second Tuesday of the month, from 11 to 2 p.m. GMT or 1 to 4 p.m. South Africa time or Central Africa time, we have a policy workshop where we discuss different issues. In 2021, we had 12 workshops, and these are the topics that were discussed. In 2022 so far, we have had 7 workshops, and we still have 3 more workshops to do. We do them up to November. So we have 3 more workshops to do. On the next workshop we are having is actually next week, on the health and well-being of primary healthcare workers in Africa. And then we'll have one on the role of women in primary healthcare in Africa and health equity in primary healthcare in Africa. So that is how we are engaging in the policy space. And these are just other topics we are considering, because we're also considering more topics for the 2023 workshops. And out of these workshops and discussions is what has come out of it is what we are calling the Building the PHC Team for UHC in Africa document, because we realize that the primary healthcare team is essential in carrying out any primary healthcare activities, and we need them to just work as a team and not work as individuals or as specific cadres in silos. So we will have an opportunity to discuss the document later on in the meeting. Then moving on to other activities that Afro-PHC has been doing, we have training. We have the Leadership Management and Governance for Health System Strengthening Management course with AMREF. So in 2021, we engaged 798, and 18 completed and 92 were in progress then. So we realized people need a bit more encouragement and support to finish the course in training. So in 2022, we are engaging in monthly meetings or discussion groups so that we can help each other better digest concepts and also move on with the course. We have a CPD meeting every Thursday. in conjunction with the NGO, which is called the World Continuing Education Alliance. We usually have 500+ people. We are also in the process of developing the framework for a curriculum for an online primary healthcare course, a diploma, primary healthcare diploma for nurses, clinical officers, and general practitioners. In terms of research, we have the ARM, which is the Afrophc research group, where we had 298 people interested, and the motive or the objective of this group is to grow African-based primary healthcare research. So we have mentors who have volunteered to mentor young researchers and help them at the end of the day. So let's see who that is. Let's mute. Okay, so, okay, moving on. So the research project is, so far we have 19 researchers who have submitted proposals, and we are hoping that by the end of the year or by the end of the program, they'll have a completed research proposal, which can also even be used to gain funding for research, for further research. And every Tuesday, every first Tuesday of the month, we have a research meeting in order to support the researchers and also to teach them more in terms of research. And as part of the research program, we are also part of a global, of an international conglomerate that has come together to collaborate around the Africa Population Cohort Consortium. So we have received a grant under this, and the whole purpose of the grant is to develop this, this consortium specifically for Africa, which is a great achievement for Africa, and Afrophc is a part of that. And apart from research, we are also engaging with our members a lot in terms of communication. We have a website, afrophc.org. If you go to that website, you will find everything about Afrophc, including all the programs you can get involved in, from research to policy. You just need to register on the website. There's a place for registration. You register as a member. You get onto the Google group and you'll be receiving information on that. And as to do with membership also and registration, the board voted earlier this year to have paid membership, whereby we will have members who are eligible to vote and others who are not. So it depends on what kind of membership you want. Information about that will be rolled out soon as we are setting up structures around that. In terms of social media, we have Facebook, we have Twitter, we have YouTube, so you can go to all our pages and see what Afrophc has been doing. And just to further the engagement with members more at a regional level, we have the WhatsApp groups. When you go to our website, you can join the WhatsApp group that pertains to your region. And we have facilitators who are executive board members of Afrophc and others members of what we call the Afrophc Executive Coordinating Team. And they will help facilitate discussion and engagement at the regional level. In terms of administration, we have the Executive Coordination Team, which is a team of young people and also anyone who is an Afrophc member who is willing to help with the Afrophc activities. Being an NGO also, we do not have the capacity yet to engage and pay people to do a lot of the things that need to be done. So we are depending on a lot of volunteerism, which has been great so far. So the members of the executive coordination team are actually people who have volunteered to take up different tasks in order to support Prof. Shabir, who is the executive coordinator. We have a strategic and operational plan, which you can find on the Afrophc website. Our membership so far has grown to 1,152 from over 40 countries across Africa, and we have all cadres of healthcare workers as our members, including non-healthcare workers who play in the policy space and anything related to primary healthcare, such as health economists. They've also been part of, they're also part of Afrophc. in terms of what we have so far in terms of how do we take Afro-PHC forward from where we are right now, one of the ideas was developing country level chapters. That's how you see we have this meeting today. We decided let's start regionally first. Once we establish a more regional connection, then we can move down and establish chapter connection, because members had desired a more country-based or country-level engagement of Afro-PHC with the members and also with policymakers. So that is how this process came along. And also strengthening links with supporting organizations, setting standards for PHC practice and also for members, including community voices more in Afro-PHC policies and activities, doing more fundraising, and also at least in terms of governance, having a virtual AGM or conference, or even thinking of having a physical one for more engagement. So those are some of the ideas we were thinking of in terms of this is where Afro-PHC is. So how do we move Afro-PHC from where we are to a different level, to more engagement and to making more of a difference in Africa? So the Afro-PHC chapters, we are now doing chapter engagements in terms of learning just how different regions are with their challenges they're facing within their regions, and also with the things that they're interested in terms of moving PHC forward. So we are building more of a regional membership. So I'm hoping a lot of people who have joined today or will join later will be members of their regional chapters. And from there, we can see how we can collaborate more in terms of country level or regional level projects and engagement with policy makers at that level as well. So with that, I am going to stop for a while and we can have some questions or comments from the participants. I had seen someone had raised their hands. Let me check if there's anything on the chat. I've seen someone who was asking how they could register. And for that, you just go to the Afro-PHC website. Eli Bajo has posted it there, and you can register as a member. There was someone speaking. Please go ahead.
Okay.
Okay, maybe they unmuted accidentally. Okay, so I'm not seeing any hands or any other comments. Oh, Shirley was asking about Shirley, there'll be another meeting for the West Africa chapter. You can just stay in case you just want to listen and learn, but there'll be a chapter engagement for each region. So there'll be another one for the West Africa chapter.
Okay, thank you. Okay, thank you. Thank you.
So any other questions or comments? So if there are no other questions or comments, I'd like to invite my colleague Jamie to share on the call to Africa, which is about the draft policy framework. I don't know, from a show of hands, has anyone read the draft policy framework on building the PHC team for UHC in Africa? Anyone? I am not seeing any hands. Nobody has read the document. Okay, so I hope after this we'll read that. So that will make it difficult for us to have a discussion around the document if people have not read it. But what Jamie, sorry? Okay, so Jamie?
Hi, yes, Mercy. Thank you so much. Let me just try and share my screen and see. Yeah, there we go. Can you see the presentation? Let me just put it to slideshow. Okay, great. Is it fine if I start, Mercy?
Go ahead, Jamie.
Okay, thank you so much. So as I mentioned earlier, but for those who joined maybe a little bit later, my name is Jamie Colity. I am a medical doctor from South Africa, and I am a member of the Afrophc Executive Coordinating Team. And I would just like to do this presentation on the call to Africa on behalf of Prof. Shabir Musa. And basically, it's a short PowerPoint presentation that essentially summarizes a lot of the key points that are written within the policy document. So, excuse me, for those who have not read the document yet, this will highlight the key points, but it definitely does not act as a substitute for reading the entire document. So I think I would encourage everyone to do so. So here on our first slide, we see Afro-PHC's call to Africa to join Afro-PHC and build effective primary healthcare teams for universal health coverage in Africa. So just a bit of an overview. So as a background, Afro-PHC wants to heed the call of African health professionals, as well as recognize those challenges and opportunities that are unique to Africa, as well as note global primary healthcare milestones. And the key elements of this call are to train, recruit, and maintain a sufficient frontline primary healthcare workforce, as well as to support primary healthcare with resources and build robust primary healthcare systems. So those are the three key things that are going to be discussed within this presentation: is workforce, resources, and systems. So in terms of the PHC workforce, we want to strengthen human resources for primary healthcare. We call on Africa to build a larger, better trained primary healthcare workforce with more opportunities, whether that's educational, financial, and clinical opportunities, and greater resources to enable primary healthcare and universal health coverage, as well as build the team with task sharing and supportive supervision. We call on Africa to acknowledge the burden on all cadres in primary healthcare and embrace interdisciplinary teamwork with a mix of all health professionals, using respectful task sharing and supportive supervision for achieving PHC and UHC in Africa. We also want to build distributed leadership. We call on Africa to embrace distributed leadership practices and education for it amongst all PHC workers and managers to achieve primary healthcare and universal health coverage in Africa. We also want to build clinical governance. We call on Africa to embrace the important role of postgraduate trained family doctors in decentralized primary care settings to support clinical governance, coordinated care, and efficient referrals to achieve primary healthcare and universal health coverage in Africa. Still under the primary healthcare workforce, we want to professionalize community workers. We call on Africa to standardize, professionalize, and decently remunerate community healthcare workers that are strongly integrated with the PHC team. And furthermore, to aspire to a target of 1 CHW per 1,000 persons by 2040 to achieve PHC and UHC in Africa. Manage human resources better. We call on Africa to clarify and harmonize PHC workforce nomenclature for the different categories and disciplines in PHC, and to then embark on labor market analyses in PHC, including both private and public, and specific PHC human resources for health policies, and strategic plans to scale up the PHC health workforce by 2025 to achieve PHC and UHC in Africa. Still under the PHC workforce, we want to develop human resources better. We call on Africa to implement a robust educational and credentialing infrastructure for developing a competent workforce dedicated to delivering comprehensive PHC services necessary to achieve UHC in Africa. Moving on to PHC resources, we want to view political and funding action for PHC as an investment. So we call on Africa to regard health as an investment and to leverage political goodwill for action on PHC and UHC by defining PHC in budget terms, ring fencing and financing of PHC, and committing to at least 2% of their GDP on PHC for UHC in Africa, as well as to fight for global solidarity action on PHC funding pools. We call on the world to re-examine global social solidarity on PHC and strengthen contributions to PHC for UHC in Africa as a priority, starting with high-income countries increasing donor aid to 2% of their health spend, and donor aid funds allocating 30% to an African Union funding pool for integrated PHC and UHC in Africa by 2030. Furthermore, under PHC resources, we want to manage pooled funds with strategic purchasing. We call on Africa to work towards better funded single pools for UHC funding, prioritizing strategic purchasing for PHC with standard and transparent contracting of both public and private providers in empowered, decentralized units of PHC for UHC in Africa, as well as reform PHC payment with blended capitation. We call on Africa to embrace simple national contracting of PHC teams, mixed or blended capitation models, including capitation, fee for service, and performance payments to achieve holistic and responsive PHC and UHC in Africa. Moving on to PHC systems, we would like to embrace the biosocial spiritual approach for PHC.
Where are my students?
Sorry about that. Let me just go back. Embrace the biopsychosocial spiritual approach for PHC. We call on Africa to embrace the discipline of family medicine with its biopsychosocial spiritual approach to care to achieving PHC and UHC in Africa that is personalized, comprehensive, continuous, and coordinated in line with global standards, as well as envision comprehensive person, family, and people-centered PHC. We call on Africa to embrace primary care, defined by the World Health Organization as an essential level of care that needs to be responsive, person, family, and people-centered, and covers the full spectrum of care within the paradigm of One Health for PHC and UHC in Africa. Furthermore, under PHC systems, we want health in all policies for robust PHC. We call on Africa to prioritize PHC as the foundation for UHC, making health in all policies an integrating and developmental public health approach to decentralized government, strengthening the role of PHC facilities with flexible models of non-hierarchical interdisciplinary teams, and creating integrated care models of public health service delivery of PHC and UHC in Africa. We also want to build quality in PHC, for which we call on Africa to embrace the culture of quality and patient safety with strong teamwork, and to measure and monitor performance to achieve quality PHC and UHC in Africa. Furthermore, under PHC systems, we want to build the district health system, for which we call on Africa to place their trust in their frontline PHC workers with decentralization of resources and the locus of control to bottom-up units of care, together with robust management functions to deliver on agreed upon results and operational accountability to implement PHC and UHC in Africa. We also want to empanel defined populations to a defined team, for which we call on Africa to embrace the strategy of empanelment of a defined population and linking them to a defined, fully staffed and equipped PHC team as a foundational step to achieving PHC and UHC in Africa. We also, under PHC systems, would like to develop community-orientated primary care for Africa, for which we call on Africa to embrace community-orientated primary care in community practices of 30,000 by 2025, and inspire to community practices of 10,000 for achieving PHC and UHC in Africa by 2040. The blueprint for rural and marginalized health, for which we call on Africa to embrace the blueprint for rural health and rural-proof all health policies to support rural and marginalized primary health care comprehensively, especially creating step-ladder entry requirements for educational institutions and rural marginalized student immersion for the full PHC team to achieve PHC and UHC in Africa. Furthermore, under PHC systems, we want innovative e-health that is patient and user-friendly, for which we call on Africa to embrace the variety of e-health solutions for PHC by ensuring that sustainable national e-health strategies are supported by accessible infrastructure, interoperability, and user-friendly designs that enable the PHC team and patients and populations to enhance quality and support new models of care in PHC and UHC in Africa. Finally, just in conclusion, we call on Africa to empower and build an effective PHC team to achieve PHC and UHC in Africa. We, as the African Forum for Primary Healthcare, commit to educating and empowering our members to support this goal in any way we can. Thank you. That is the end of the presentation on our call to Africa. So I'm going to stop sharing. I don't know if anyone has any questions, or Mercy, if you have any additions on the call to Africa presentation.
Thank you so much, Jamie. I think it was well done and clear. So just to get everyone back on board, that is just a summary of what is in the policy document. There's still so much more on that. And I'm hoping we have read it or we will read it. And for now, we are going to move to the discussion portion of the meeting, because the whole purpose of this meeting was to get the views of and the comments from the people on the ground from all Africa regions, today in the Central Africa region. And to take us through that session, I am going to hand over to Dr. Eli Badjo.
Thank you, Dr. Mercy, and thank you, Jenny, for all those presentations. Je vais préférer parler peut-être en français, comme tous les intervenants précédents ont parlé en anglais, pour équilibrer un peu les débats. Je crois que nous avons maintenant les sessions de discussion. C'est pas, Dr. Mercy, si vous me permettez, qu'on passe directement aux discussions. Nous avons des discussions. La première, ça va concerner quels sont les défis de soins de santé primaire dans la région. Et deuxièmement, par rapport au document qui vient d'être résumé par Dr. Jamie, nous allons discuter aussi quels sont les éléments à ajouter, qu'est-ce qui ne va pas bien, et donc même vos suggestions. Je préfère que nous puissions faire les deux au même moment. Est-ce que ça va? Madame Françoise, est-ce que ça va comme ça, si nous prenons les deux discussions au même moment?
Oui, je crois que c'est bon. On peut aborder dans ce sens.
D'accord. Et donc, tous les participants, vous avez la parole maintenant. Pour,
maybe, Ellie, you can, so that we can have the issues not mixed up, maybe we can discuss one, then the other. Like maybe we can go through the challenges within the region, and then from there, maybe we move to the documents and see if there's anyone who has read it, and then we can discuss the document so that we can capture all the elements of the discussion clearly and not mix them up, because Jamie is taking minutes for this meeting, and I think it would be easier for her if the two were clear and separate.
OK, thank you also. Donc, nous commençons par les défis des soins de santé primaire dans la région. Et après, à un moment donné, nous allons passer au deuxième débat. Donc, le débat est lancé.
Yeah, we can start off with the PHC challenges in the region.
Yes. Quels sont les défis maintenant des soins de santé primaire dans la région de l'Afrique centrale? Nous savons que l'Afrique centrale contient plusieurs pays et presque tous les pays sont représentés dans cette réunion ici. Vous pouvez parler par rapport à votre pays, ou soit si vous avez voyagé dans un autre pays de l'Afrique centrale, vous pouvez aussi parler de ce que vous avez trouvé là-bas, sur base des expériences vraiment qui sont sur terrain, et ça va nous aider à enrichir et savoir tous les défis pour que les forums africains pour les soins de santé primaire puissent aborder surtout les défis et voir avec tous les leaders qui se réunissent ensemble comment aborder les défis et trouver des solutions. Sentez-vous à l'aise d'élever votre main si vous avez quelque chose à aborder dans le débat. Je ne vois pas une main levée. Nous avons besoin de vous écouter. Hein? Sentez-vous à l'aise, vous pouvez intervenir en français comme en anglais. Nous avons notre interprète Alexandra. Et donc, vous pouvez choisir soit intervenir en français ou en anglais. Oui, Michel, vous avez la parole. Michel Mabo.
Thank you. Thank you for the presentation and good day to everyone. I'm sorry I wasn't part of the meeting from the very beginning, so I might have missed some very important points. But talking about the challenges to PHC in Cameroon and the role of community health workers is one of the things that I would want to highlight. I think that the way we have traditionally used community health workers has mostly been in vaccination campaigns and programs. And it's like these people are called in only when there is this kind of program. They're given some training. and then they work for that program, and then it's okay, see you next time. So I think that if we can actually make these people who work as community health workers begin to see themselves as real professionals, a real part of the healthcare team, of the primary healthcare team, a real part of the system, we can get more out of them. Because in many of our rural areas, there are places that only these community health workers access, because maybe the health centers are quite far off and you only have to depend on these people. So I think that that's a challenge that we are facing, and that should be addressed. Secondly, there is no formal training. I'm very much involved in the education of health professionals, but we do not have a structure that gives these people training. They're usually just recruited from the communities, trained for a purpose, and then disbanded after that purpose. So those are two things that I can highlight at this point in the discussion. Thank you.
OK, merci beaucoup pour ce point-là. C'est très intéressant par rapport aux agents de santé communautaires qui ne sont pas vraiment accompagnés. Je crois que c'est un défi qui s'observe presque partout. Voyons aussi, ça c'est au Cameroun. Voyons ailleurs. Je vois une autre main levée. Florine, vous avez la parole si vous voulez parler. Je vois Nadège qui écrit dans le chat, les soins de santé primaires sont un réel défi au Cameroun. Il existe des zones enclavées qui n'ont pas accès à l'eau potable, au paquet minimum en matière de santé principale. Il s'agit de l'accès aux médicaments essentiels. Aussi, les populations se tournent elles-mêmes vers la pharmacopée traditionnelle. Comment Afrophc pense se déployer pour relever les défis de l'accessibilité aux soins? OK, je crois que c'est aussi une question. Donc, c'est un défi et une question adressée à Afrophc. Je crois que ça, la deuxième partie de votre intervention, on va la réserver pour la dernière discussion, parce que nous avons la discussion comment nous allons aussi appuyer ou faire avancer Afrophc dans la région. Afrophc, c'est tous les acteurs, donc vous aussi y compris. Je ne sais pas, mais si vous pouvez avoir quelque chose à ajouter, à dire par rapport à la question qui est adressée par Nadège. Merci. Can you say something about that? How Afrophc can help to these challenges to accessibility?
Plan. It's not small, though. 1,500, 250 is not small. There was a banker in UK.
Michel, vous voulez revenir encore une fois? Vous avez la parole.
Yes, the next issue is another challenge that I see in Cameroon is I don't want to say lack of, I would say the insufficient contribution of the private sector. The private sector is not really leveraged in PHC efforts. There is more that the private sector can do. And when I talk about private sector, it's not just about clinics and health centers. It's also about NGOs. It's also about NGOs that work in healthcare or that work in other areas, not directly in healthcare, but whose interests have implications in healthcare as well. So I think that we have a challenge there to be able to leverage these different sectors, especially the private sector, in contributing to achieving PHC goals. That's something too that I think requires attention in this plan.
Okay.
Thank you.
Thank you for that, Michelle. Just one question to you, Michelle. How in Cameroon you can capture data from private sectors? Do you capture that in the health system, or it is also a challenge in Cameroon to capture data, primary healthcare data from private sectors? Ah, voilà. Françoise, yes.
I don't know if he got your question. I don't know if Dr. Michelle got your question. Is he still there? Okay.
Dr. Michelle.
Yeah. Oh, actually, if I have to say something there on the question you asked, we have a whole department in the Ministry of Health on primary health care, but on the field, you don't feel them that much. You don't feel their impact that much. But we have a challenge of in Cameroon, we have the health areas that are found under the districts. But in some communities, the health area just have one or two human resource. And so it's really not, does not really cover the different communities. So the primary healthcare units are really not functioning the way it's supposed to. And if you go now into the primary healthcare, you see that all the elements are not found in those communities. So patients are forced to look for an alternative. That is where you see them go for alternative medicine. So we really need a government to come in play in place to really restructure and redynamize our primary health care. But if not, like Nadesh said, we don't know how Afrophc can help also in this fight, because I've always brought that up with Prof. Shabi from the beginning. Before we even created chapters, we really have a very big challenge on the field. What we use here as community health workers are we have what the ministry calls the dialogue structures, where we have the health committee and the management committee that works directly under that. But they are just usually very few. They can't cover the whole community. I think on our own part, we really need to redynamize. For example, I work in the rural community with about 5 villages, and I'm training health workers in that community. And sometimes we do multidisciplinary approach where we put the nurses and the community health workers in such a training, and then for them to go on the field. And presently there is a work we are doing on sickle cell disease, where we are training these community health workers to do a home treatment, to go from house to house and visit. It's a pilot work we are doing with sickle cell disease. So actually I'm fully involved in that. So we're training them to go do some work on we're training them to help sickle cell disease patients. So it's not only on vaccination, like Dr. Michelle was saying, because actually that's what the country use them for. It's only when there's vaccination they come out and have some work. But we want to see how we use them continuously in that community. It can be in anything. We can just train them how to teach mothers to do ORS, and they'll be very helpful in the community. So there should really be a redynamization. And as concerned as a private sector, like he was saying, probably I think he's trying to talk about the civil society organizations. We have civil society organizations on the field, but they really don't work hand in hand with the primary healthcare structures, which should be another asset we should also, because some of them come with good health programs that are implementing, but it is fragmented. So, but if they can merge it together, I think they will benefit more. So there's a lot of hands. Oh, let me allow others to talk. I'll come back again later. Thank you.
Merci beaucoup, Françoise. C'est très intéressant ce que vous parlez. Je crois que Dr. Jamie va prendre ça comme aussi une grande recommandation du point de vue Afro-PAC. Si on peut commencer aussi à penser des activités d'approche communautaire pour faciliter l'accessibilité aux soins de santé primaires. Et aussi, même, pourquoi pas, ces défis qui reviennent toujours ne sont pas accompagnés, alors que ce sont des agents clés dans les soins de santé primaire. Je pense que cette recommandation est capturée et sera bien reformulée par Dr. Jenny. Je vais lire quelques recommandations, quelques contributions qui sont dans le chat avant de donner la parole à ceux qui ont levé le main. OK, je vois d'abord la contribution de Nadège, on l'a déjà dit, Lee. Il y a la contribution
Michel se plaint d'audio.
Goran.
Je ne sais pas si audio est bien, whether the interpretation is functioning well. Michel se plaint qu'il ne suit pas.
Non, apparemment, il s'était déconnecté un peu. Hein? Je ne sais pas. Docteur Michel, ça va, je pense.
Yes, I can hear now. Thank you.
Okay.
You're welcome. Okay, in my own opinion, the private sector is doing a lot of in Cameroon. Okay, that is a contribution of Goran. Just to add the challenges, most community health workers are demotivated in health activities as they feel that they are used by the health workers. I don't know if Lemundam can explain that opinion. Okay, Lemundam,
yeah, good afternoon, everybody.
Okay, good afternoon.
So I'm Lemundam from Cameroon, and I think I've worked also at the district level, at the health center level, where we have community health workers. As Dr. Mabu said, most of the we invite them, bring them in most of the programs, and then we just allow them to go. And for instance, if in a program where, let's say, a vaccinator is receiving, let's say, a certain amount for motivation for the program, the community health workers normally they give them just something very little. So some of them, when they look at it, they don't actually feel more motivated. And meanwhile, they go into the deeper communities to actually sensitize the people, to actually give the information concerning the particular program. And it is being said, as it has been said, they are being involved mostly in particular program. Why I'm raising my head now is concerning the private sector. With the private sector, it is actually a challenge for them to actually be involved in community, in a primary health care, in that, one, being a private sector, they are under a different leadership. When they are giving, some of them, they have health areas or they are operating under health areas. But when it comes to carrying out the real activities, they don't put in their maximum because they have focal persons. Those focal persons, they need to come and do the primary health care activity, go back to their sites or their centers to carry out their central activity. So it makes them now not to actually input what they are supposed to do. Like if there is a program that we say, okay, a health area being manned by a private sector has to carry out, the one being run by the government sector carries it effectively. But the other, if they don't give them permission, they might not even do the activity because they tell them that that one is not the work where they were employed to do. So it's actually a challenge, which I don't know how we need to, I don't know how we can do to actually integrate them so that they should see the need of actually being participating on those activities very well. So that's my contribution. Thank you. Over.
OK, thank you for that. Je vois, on a déjà encore écrit, les données sont souvent déclaratives dans le secteur privé. Il est toujours difficile d'avoir accès à des documents qui peuvent corroborer les déclarations des agents de santé sur le terrain. OK, merci pour ça. Moi, je vais donner peut-être une contribution pour l'expérience pour le secteur privé en RDC. En RDC, c'est aussi un défi. D'abord, le gouvernement n'a pas assez de structures. Nous avons maintenant aussi des structures qui sont, je ne sais pas, je peux les appeler privées, ils sont accrédités par l'État, mais ils sont confessionnels. Ça veut dire qu'elles appartiennent aux confessions religieuses. Et là, l'État a difficile à contrôler ces structures. Donc, l'État a peu de structures et beaucoup de structures sont privées et confessionnelles. Ce qui crée aussi un grand défi dans la mise en pratique même des politiques sanitaires mises en place par le gouvernement, donc les autorités sanitaires. Parce que le secteur privé a ses injonctions et aussi le confession. Aussi, ça, ce n'est pas un problème parce qu'il contribue bien sûr à l'accessibilité aux soins de santé primaire, mais un plus grand défi aussi, c'est l'accessibilité au matériel. Également l'accessibilité même aux médicaments. Vraiment, c'est un grand défi, surtout dans les zones rurales. C'est un grand défi. Aussi, un autre défi en RDC, mais quand même une stratégie que je peux donner qui est positive, et que avec le nouveau décret présidentiel qui veut mettre en place la couverture sanitaire universelle, il y aura une stratégie de l'accréditation des structures privées qui seront prises en compte par l'État. Et là, ils vont être aussi intégrés car seront accrédités. D'abord, c'est ce que je pouvais donner comme contribution. Laisse-moi donner à John Walasa. John Walasa, vous avez la parole pour votre contribution avant qu'on passe à une autre discussion. John Walasa, on ne vous capte pas. Je ne sais pas c'est quoi le souci. Je ne sais pas si vraiment le problème c'est à mon niveau.
Okay, while
Madame
waiting
Françoise, je ne sais pas c'est comment de votre
yes, while waiting for John to come up, I think we really have an accessibility problem. I've been in communities where a pregnant woman walks for more than 7 to 8 kilometers, some even 11, to get a primary health care center where she can come for her antenatal. And when she finally gets there, all the services are not available. You see, now we have the problem of accessibility, we have infrastructure, and then we have the human resource. See, we have the human resource. Sometimes you see beautiful buildings in those communities, beautiful building, beautiful structure, but if you get in there, you can't find a good or comfortable bed a woman can be on to deliver. The staff are not there. You see, there is no, if you go to the labor ward, for example, you really not see what is needed to really run a primary health care aspect of the delivery there. So we really have problems in that area. So the number of population, normally they're supposed to have a particular population with a certain number of health areas so that accessibility will be easy. But we don't really respect that. And Nadesh was trying to talk about some private sectors that are working. That's why I said that they are working is true, but it is not felt at the level of, because they are not integrated in the policy. So there's a lot of organizations that come and implement this work, implement that work, implement that work, but at the end, it is fragmented. Meanwhile, they could have really been harmonized to get maximum impact. Yes, Grace. I don't know if John is now hearing us. Madame
John,
Ngora.
vous dites que vous êtes de la RDC, vous voulez ajouter quelque chose, mais on ne vous capte
Thank
pas,
you so much.
désolé.
I just want to talk about this accessibility in the communities. Actually, if our government from the beginning, they laid a very good foundation as far as the primary healthcare is concerned. But as time was going on, there was a time that they did not value these community healthcare workers. And what the private sectors is doing now, particularly the CVC that I'm working with, they have primary healthcare centers all in the 8 regions of Cameroon, and they have field supervisors, and they have the trained community health workers, so that in each community, even if a woman is about to deliver, there is a trained birth attendant there. They call it COMCA, community health, whatever, but they're doing a great job. And they are sending their statistics to their various districts, and which is supposed to be forward to the region and particular and maybe to the national. So it's just for us to really see how we can push forward, how we can empower more private organizations to embark on this. For the government, yes, they have such facilities, but when you go there, people that have even been sent there by the government, they go and put people that they don't even know, and in case of an emergency, they don't even handle. So those are some of the problems as far as PhC is concerned in our country, Cameroon. Thank you. Over.
Thank you very much, Nadej. Ngora Grass. Okay. John,
Yes.
John Walasa, can you unmute yourself?
John is unmuted, but I don't know why we can't hear him. John, probably you should check your audio settings. Just go to the mute button and check your audio settings, and maybe connect the right speaker, because we can't. You're unmuted, but we can't hear anything from your side. Or you can log out and log into the meeting again.
That is. Okay. Let me give another problem, another challenge from DRC. Nous avons un autre problème parce que nous avons un autre problème parce que en RDC, on a une situation souvent à l'Est, là où aussi je suis, un problème de déplacés internes dans des milieux où il y a des conflits armés. Et maintenant, les déplacés internes qui ont difficile à payer les soins, et ils ont aussi difficile à l'accessibilité aux services de soins de santé primaires. C'est un grand défi et aussi que nous observons en RDC. Mais la stratégie qui est beaucoup plus mise en place, c'est grâce à l'appui des ONG, mais aussi ceux qui sont partis loin des structures de santé. Il y a l'approche des cliniques mobiles qui aident à rapprocher les services de soins de santé primaires vers eux. Mais malheureusement, ces cliniques mobiles n'ont pas toujours un paquet complet de soins de santé primaires et l'équipe n'est pas toujours multidisciplinaire. Soit c'est seulement un médecin et 3 infirmiers et c'est tout. Donc, ce n'est pas complet dans les paquets de soins de santé primaires. Merci.
Ce n'est pas complet et ce n'est pas régulier.
Exact. Je pense qu'on peut passer à l'autre thème de débat. Je ne sais pas. Merci. Do you allow us, Françoise?
Pardon?
Est-ce qu'on peut passer à l'autre point de débat pour discuter un peu sur le document maintenant, comme on a quelques dossiers, quelques défis sur,
Okay.
dans la région?
Mm-hmm.
Voilà.
That's all right, Ellie. Go ahead.
OK, thank you. Je pense que nous avons tous, celui qui n'a pas encore parlé, quelque chose comme défi. Nous allons les lire et et ça va ressortir également dans le PV de la réunion. Parlons un peu maintenant du document tel que le Dr Jamie l'a présenté. Afrophc a mis en place un document politique ou un cadre politique qui permet qui facilite un plaidoyer au profit des soins de santé primaires. Je pense que vous aurez le temps peut-être de les lire sur notre site Internet. Également, par le peu que vous avez écouté, par le peu que vous avez écouté, hein, je vous demanderai de donner qu'est-ce que vous pouvez suggérer qu'on ajoute et qu'est-ce que vous n'avez pas compris. Vous avez donc la parole. N'hésitez pas à lever votre main et parler. On va vous accorder la parole. Scott, vous voulez parler quelque chose? Scott Wolf. Apparemment, c'est pas accident, on peut le muter. La main de John, je vois toujours levée. OK, John a écrit dans le chat, c'est très bien. En attendant que vous donnez votre contribution sur les documents. En RDC, nous avons aussi les problèmes liés au non-encadrement des médecins par le gouvernement. Et cela fait qu'il y ait des grèves du personnel soignant, faisant que les données ne soient pas remontées. OK. Deuxièmement, il dit qu'il y a le cas de IDPs, donc le déplacé interne, qui date de plus de 10 ans, sans intervention efficace. Troisièmement, il dit que l'encadrement des zones ne facilite pas l'accès au matériel. Et puis, il dit aussi qu'il n'y a pas d'engagement efficace de la communauté dans une zone avec le cas d'Ebola à Butembo, où des structures sanitaires étaient vandalisées. 5, il dit que nous avons un contexte récurrent de mouvements de population dans plusieurs zones à l'est de la RDC. Et en fait, il dit qu'en RDC, il y a des zones endémiques. OK, je crois que c'est des bonnes contributions. Il y a ces grands problèmes de défis là de contribution ou participation communautaire. C'est un grand défi. Nous attendons vos contributions par rapport aux documents politiques sur construire une équipe multidisciplinaire des soins de santé primaire pour la couverture sanitaire universelle en Afrique. En fait, comme on l'a dit au départ, les soins de santé primaire ne peut pas être une question seulement du médecin, non plus une question seulement de l'infirmier ou de la sage-femme ou du laboranté ou de quelqu'un de santé mentale. C'est quelque chose qui doit être réglé ou géré en équipe. Et voilà pourquoi Afrophc a mis en place ces documents de plaidoyer, ces documents politiques qui veut mettre en possession de l'Afrique pour accompagner les stratégies de mettre en place une équipe multidisciplinaire qui va travailler ensemble en fait d'arriver à l'objectif de la couverture sanitaire universelle en Afrique. Et donc, on a besoin de vos contributions. Qu'est-ce qui n'est pas clair ou qu'est-ce que vous pouvez suggérer que ça soit ajouté selon les réalités que nous venons de voir qui sont dans notre région?
Je ne sais pas si on a aussi regardé l'aspect financier parce qu'ils ne sont pas bien rémunérés. Il n'y a pas vraiment, les zones sont vraiment, la route est vraiment, non seulement il est loin, mais les routes sont vraiment impraticables parfois, surtout en saison pluvieuse. The road is very, very inaccessible, very, very, especially during rainy season. To really get to a PHC center is with a lot of difficulties. And also the pay package is really doesn't encourage many to function in those PHC in the rural communities. I don't know if it is the same thing in RDC, but we have that aspect. And then the capacity, there's no continuous training. So they are just left there with some knowledge, and we really need to invest in continuous training so that they'll be up to date in some practices. Yes.
Of course, Francois, it is the same challenge in DRC. There are some areas which you can't access, they are not accessible. The road is not accessible. It is the same challenge in DRC. I think also that what you are adding about the finance, we can see in the document if something about the finance is added. I don't know how many percent is allowed for PHC in Africa, because for health, the World Health Organization said about 15%. I mean 50% of the budget must be given to the health. I don't know what the document said. Dr. Mercy, can you tell us a bit about the document on the finance issue?
So I was really hoping that people had read the document, because it would be easier and to comment on it if you read it. It's about, is it 18 to 21 pages? But in the issue of financing, what the document recommends is 2% of all healthcare expenditure should go to, at least 2% of the budget should go to healthcare. But we are saying that that is up for discussion, because that's just a recommendation from the Lancet, from a document that the Lancet released the other day on primary healthcare financing. So the recommendation on the document is 2%, but we are actually thinking that we could go higher. That's why we're doing these consultations and seeing in different countries, like in Central Africa, in your countries, how much do you put aside for UHC, and I mean for PHC, primary healthcare, and how much do you think your governments should put up in terms of primary healthcare spending?
Thank you for that. The question is open for discussion. N'hésitez pas d'élever votre main ou d'ouvrir votre micro pour votre contribution. Docteur Michel, il n'y a pas quelque chose à ajouter pour les documents?
I sincerely, I think that document covers a lot of aspects that is really supposed to figure in the PHC. But the challenge is that it is not a reality in our different countries. So I think what we should be saying here, how do we come up to the state of this policy? What can be done to bring up, to bring our PHC to this state? So I think some of us here have some civil society organizations that operate at the community level. Dr. Eli, I think so. And so some of these aspects is not just we saying, I think we should also start implementing it and encourage others. Yeah, that's my take again.
Okay. Okay, I see there is no other points for attendees. Let me see in the chat. John Walasa, again, something about challenges. Pour les documents, ok. Pour les documents, il faut renforcer il dit qu'il faut les renforcements de l'engagement communautaire, ajouter l'aspect à la logistique pour l'accès. Nous devons aussi réfléchir sur l'aspect de la cohésion sociale intercommunautaire qui sont parfois les causes de mouvements des populations. Ça, c'est très important. Et réfléchissons aux aspects du changement climatique. Et puis, il dit aussi que les effets des catastrophes naturelles telles que les inondations, les éboulements, les éruptions volcaniques doivent ressortir. Je ne sais pas comment vous le suggérez, malheureusement, on ne parvient pas à vous capter. Aussi, en fait, il dit qu'il faut aussi les renforcements des prestataires primaires, des soins de santé primaires, tels que les relais communautaires. Je crois dans les documents, il y a une partie qui est réservée aux ressources humaines. Pour les renforcements de capacité, tout ça est ressorti dans les documents. Mais c'est bien, merci d'avoir encore soulevé ces points. Donc, ça va attirer encore l'attention sur les renforcements des prestataires des soins de santé primaires, surtout les agents de santé communautaire. S'il n'y a pas autre chose, je vais remettre la parole à Messi, qui était le modérateur de la réunion. Dr. Messi, over to you. I think we are at the end of discussions.
Thank you so much, Ellie, for facilitating that discussion. For those who have not read the document, I'm just encouraging you to go back to the website. The document has been posted there. You can click on it and read it, because this I forgot to say at the beginning, that Afrophc received a grant from CPI towards the development of this document. So we are going to have consultation meetings with chapters, regional chapters from all over Africa, to see what they think about the document and what can be included in the document, or what needs to be changed in the document. So this is actually the first of many consultations towards that. And then in October, we are going to have a physical meeting with stakeholders from the Afrophc Executive Board, the Advisory Board, and other important stakeholders who have been supporting Afrophc, so that we can sit down and collect everything that you have said, everything we have discussed in these meetings, so that at the end of the day, it is a document that is owned by us all, and it is also able to be applied within different contexts, because the different contexts have been considered and applied in the writing of the document. So if you still have any more comments, the discussion can still go on in the WhatsApp groups. And you will also see more information about the PHCPI grant and about the development of this document and the October workshop on our website, and also our various social media sites. I just want to say thank you for the members of the Afrophc Executive Board who have been able to join us today. Thank you, Ellie, for facilitating the meeting. Thank you so much, Jamie. It's a Friday afternoon and it takes commitment to be here. So thank you very much. In case you have any more comments, you can also send an email to, I'll just put the email on the chat, and we will get to it. In case you have any other comments or additions or questions in terms of Afrophc, and also, oh, sorry, I've not finished that email, Afrophc and also the document. So I'm going to ask the president, the deputy president of Afrophc, Francois, to say some closing remarks as we end the meeting. Francois, over to you.
Oui, merci beaucoup. Thank you, Messi and Jamie. Thank you, everyone in this platform that has honored this consultation meeting. And we really value your time. We value all the suggestions that you've made here. Like Messi said, it's a document we are still putting up together. So all your suggestions and will be looked into and will be integrated in the document. And we really want that you come and help us to build Afrophc together. If you were there from the beginning, you see where we started, and we are still struggling to get our feet in different regions and in different countries. And all over Africa, you see there are really great challenges, and it's quite difficult. Most of our population as well, for example, in Cameroon, 43% of the population live in the rural area. And if the primary health care is not functioning, you can see the danger the population is exposed to. So please join us in our meetings. In the different forum, we've put up how to connect with the Afrophc, how to become a member of Afrophc. And in the beginning, we told you the different programs on research, on CPDs that we have. Please come, let's join together and build Afrophc. It is for us so that the future generation will not, will get a better care and sustainability we've left for them. And so with this, if there's no other thing to say, I want to thank you all and say, please join us again in our various meetings. We have several meetings that if you go to our website, you see lots and lots of information. And like Messi was saying, for those that are interested in research, I think the date was extended to the 15th of this month. If you want to still write a research, and that others will look for a supervisor, or if you're a supervisor, you want to mentor a student in a research, there is still an opening. We have up to 15th of this month for that aspect to be closed. But do join us every Tuesday when we carry out our research and our policy brief document. Thank you very much. Have a nice weekend to you all. Bye.
Bye-bye, everyone. Thank you.
Bye. Bye, everyone. Enjoy your weekend.
Bye, everyone.